the first question that we got in. This is a patient with Ehlers-Danlos syndrome and cranial cervical instability. They also have bilateral compression of both internal jugular veins. Oh boy. And they also have thoracic syrinx in the T4, T5 region, through T9, and some scoliosis. They've been told that Chiari is not from the skull being too small. Had sitting MRI, supine flow was not blocked. How do you find out the cause of the Chiari? So I guess in this case, is Chiari the problem? So this patient, again, to reiterate, Ehlers-Danlos syndrome, cranial cervical instability, thoracic syrinx, but they may or may not have a Chiari. So what?
Well, this is an interesting question because it brings up this conundrum with the terminology. Because if the patient doesn't have choked tonsils and tonsillar compression and doesn't really have a Chiari. So as the definition of Chiari first came about after the mid-1800s, when Chiari first described autopsy cases of patients that had terribly restricted posterior fossas and tonsillar compression, spasticity, and really a terminal illness, more or less. These were the severest of the severest kind of Chiari patients who presented with occipital headache, ataxia, and spasticity because of compression of the spinal cord, and then later development of syringomyelia. This is how the definition first came about, and then we got into this conundrum of what's a Chiari? Is it 5 millimeters, or now we say that cranial cervical instability and EDS can mimic Chiari. It's not a Chiari in a sense. It mimics Chiari because the symptom presentation is so similar because of the disturbance at the cranial cervical junction, and the dynamic aspect of compression of those structures because of the instability associated with connective tissue disease, and namely EDS. So I don't know, did that answer the question?
I mean, a little bit. I guess really the question is, what really are the causes of Chiari? Because if cine MRI is not showing any kind of blockage of CSF flow, what are the different things that could cause Chiari?
It's not really Chiari, you see. Right. A Chiari, when you get back to the basic terms, a Chiari, as it was first described, was really a small posterior fossa. Now that's probably just a little bit over 50% of the cases of what we now call Chiari-related diseases. And so it was initially thought to be the whole problem, but it's not anymore because cranial cervical instability, tethered cord syndrome, and post-trauma cases and the like have expanded what we now look at as Chiari-related disorders. So maybe, to get down to it, when you look at the series of cases that we had, over 700 or 800 cases, the classical Chiari was only about 50% of those cases, The remainder were cranial cervical instability, post-trauma cases, and other odds and ends of cranial synostosis cases where there was congenital constriction of the whole brain. So it gets more complicated. Go ahead.
Yes, there are a couple of questions, and I'm going to trigger warning this a little bit because we're going to talk about suicide. Does Chiari malformation cause some inadvertently suicidal tendencies in a child? So theoretically, if the pain was bad enough, could that cause like chronic pain in such a way that maybe they could start developing some depression or serious suicidal ideation in your experience?
Yeah, that's exactly the issue. I mean, there's no association of cognitive or mental issues or suicidal issues with Chiari by itself. In my mind, it's the progression of chronic headache, and oftentimes unrealized etiology for that headache that leads many patients to be despondent and oftentimes thought to be neurotic. And as we say, you know, most patients are sent to 4 psychiatrists before they see a neurologist or a neurosurgeon, which is not the best of situations. But chronic headache is one of the most common problems in mankind. Probably about 30% of the population has headache from time to time, and many of them, for many patients, it's a very severe problem. It's not a life-threatening issue for the most part, so that it doesn't raise to the level of other disorders that are chronic and progressive, leading to terminal illness. It's more or less a wearing away of the will and a wearing away of the patient's resilience in dealing with the chronic problem that just seems to be day to day. It's more punishing than migraine, for instance, because migraine attacks are classically understood. They're 2 to 3 hour headaches that come periodically. They can be very severe, but they occur periodically. Some people have 1 or 2 a year. Some people have 1 or 2 a week. But Chiari patients oftentimes will say they have always had headache. It's one of the classical features of the Chiari. They're never free of headache. It just is punishing in the sense that when they try to do something, the headache gets worse. So there's this classical exertional component to the headache, which is punishing, you know. So every time you try to do something that for most part should be pleasant, like going on a roller coaster or riding a horse or jogging or having some physical activity, you get hamstrung by the fact that the headache becomes more severe and you have to stop what you're doing. This leads a lot of patients to actually gain weight because they don't have much activity, and increase in weight kind of aggravates the problem as well, because we add a component of pseudotumor or pressure increase associated sometimes with that, which can compound the problem of headache.
Can you speak to a little bit how the pseudotumor can exacerbate some Chiari symptoms, or?
Well, you know, where the rubber meets the road is really in the posterior fossa, where there's this choke point at the cranial cervical junction. So when you increase intracranial pressure, there is a certain impact of pushing the tonsils further down. So coughing, sneezing, laughing, crying, all these things aggravate the headache. And you know, Dr. Millerat used to say it hadn't been very well looked at, but there may be a problem with the absorption of spinal fluid as a result of chronic pressure on the absorptive capacity, the absorptive channels within the central nervous system around the absorptive areas near the sagittal sinuses. So that's not been very well understood, but in any event, patients with Chiari develop not maybe to begin with, they have cough headache and exertional headache, but as time goes on, they just have chronic punishing headache that seems to get worse when they do, the more they want to do, you know. And if you have a headache and you go to an emergency room and it's the worst headache you've ever had, you'll get a CAT scan, an MRI scan, and see a neurosurgeon. If you go to the emergency room 3 times a month or 3 times a year, you're going to get nothing, and you're going to be put in a room and getting a migraine sort of approach with Toradol and Benadryl and be sent home, oftentimes with no studies, because it's a chronic headache. And if you had a headache for more than 2 months and you haven't died from it, you probably don't have anything too serious. So you get turned around in emergency rooms. So many patients are saddled with the issue that they never really get fully evaluated early on, and they just turn into a chronic headache person, bounce from doctor to doctor, and you know, they don't get any satisfaction. So their real assessment oftentimes gets quite delayed, which is part of the problem.
Yeah. A little bit too, that something came up in the chat. A fellow Chiari sufferer recommended a cocktail of Tylenol, Benadryl, and caffeine pills for severe Chiari headaches, for her daughter's severe Chiari headaches. They've tried it several times. It doesn't seem to work, and nothing else really does. Is there any mechanism at work in this particular combination of medications? So just to reiterate, Tylenol, Benadryl, and caffeine.
Yeah, so that's kind of approach for migraine. All right, but the Chiari headache is not a migrainous headache, really. It gets treated that way because migraine is so common that if you see a headache patient, 99 times out of 100, they're going to have migraine, not Chiari. We don't approach those patients in the same way. The idea should be to identify early on the cause of the headache and treat Chiari patients more appropriately with medications that may decrease the production of spinal fluid. We use shunts, to treat intracranial pressure, but there's only one medication really, or two, that affect the production of spinal fluid. And that is Diamox, methazolamide, Neptazane, and Topamax, which also decreases CSF production. But we have very limited medical strategies for doing this, but the ones that we do have are poorly used, or not often used, So that's what we try to educate the neurology community about, because everybody's treated like a migraine, and when that fails, doctors tend to say, well, the patient's just a bad patient. It's not, if my treatment doesn't work, it's the patient's fault, so.
Right. And that's super unfair. So I guess to that, before we even move on, is how do you identify, how do you understand the difference between a migraine headache versus a Chiari headache? So what are the different things that someone should be looking out for to tell if they're having a migraine? I know I've had migraines before, but I've also had occipital headaches, which are at the back of the head. So how do you know exactly what you're having?
Okay, so a typical migraine headache comes on. Most migraine patients are totally free of headache in between migraine attacks, all right? And so the migraine attack can be triggered by some things. We know it can be triggered by red wine. It can be triggered by menstrual cycle. It can be triggered by beans that have vasoactive substances in them. It can be triggered by a number of things. Chocolate, for instance, which should be delightful, but is a well-known trigger of migraines. Processed foods, so salami and meats of that type, those can also be triggers. But the trigger for a Chiari headache is really exercise and exertion. So if the headache is exertional in nature, we got to think migraine doesn't tend to be that way. If you do have a migraine headache and you try to lift a heavy weight, you're probably going to have a little worse headache. But it's not exactly the way the Chiari patient experiences this aggravation. So Chiari patients are also likely to have headache that's almost continuous. They oftentimes will tell you, in fact, children will tell you, they don't know what a headache is because they've always had a headache. And in fact, I remember one of the first patients I saw when we were just getting together with Dr. Miller was a 10-year-old boy who was a couch potato kind of. He was a little overweight. He came in and he was not very interactive, but he was a bright young child, and he didn't really complain of headache. We finally, he was evaluated, he had surgery, and the day after I saw him, he was active and motivated. He was in the playroom on the floor, which he hadn't even gotten to before the surgery. He had railroad tracks of sutures down the back of his head, and I said, "How are you feeling?" He said, "My headache's gone." And that's an impressive statement from a kid with just post-operative from an operation like that, who said, "My headache is gone." And I said, "You never complained of headache." He said, "Well, I didn't know what I had." So it's unique experiences like that that make an incredible impression on you as to what this headache can be like. And so for many patients as a chronic headache, they really don't understand what a headache is or what a headache isn't, from childhood, So Chiari, because of the issue of the frictional forces and the thickening of the membranes around the posterior fossa, tends to present a little bit later. Certainly kids present with it, which is not uncommon, but in the adult population, patients begin to get symptomatic in their early 20s and late 20s and early 30s. Part of that is because they have continued frictional forces in the posterior fossa at the cranial cervical junction that thicken a lot of these membranes. So the restriction becomes greater and greater and greater, and it's a very gradual process that is difficult to put your finger on. The patient just realizes they're getting worse. And, you know, if you've had a headache for 3 or 4 years, you know, nobody thinks there's anything new to look at, you know. So they frequently get overlooked.
Yeah. Before we move on from sort of, we had been talking about suicide earlier. There's some cognitive issues that also come up a lot with Chiari. So a question came up in the chat function. What is brain fog, Chiari fog? And have you found any kind of treatment that's best for managing it? Is surgery the way that you kind of deal with that, or do we not even know what brain fog is and how to treat it?
I don't think we actually know. You know, it's kind of a mix of things. I mean, Dr. Miller and I, we also used to talk that maybe there was a certain amount of intracranial pressure by the resistance to forces at the posterior fossa that led to maybe pressure in the cortical structures that led to some cognitive kind of dysfunction. But there's been very little. Some people in the Chicagoland area, University of Chicago, Dr. Oro, and a few people have looked at the cognitive issues as well as us, you know, in Chiari, but it's very kind of nebulous, and it also is contributed to by oftentimes the use of pain medication and sedative medications and Benadryl and things like this that do cause cognitive clouding. And pain is a great depressant, more or less. You know, you don't feel up to doing much, and that puts the spin on, and this that leads to this idea of, you know, suicide is not something associated with Chiari, but suicide is certainly sometimes associated with chronic severe headache. In fact, you know, men that have what is called, you know, chronic cluster headache frequently commit suicide because the headaches come on in clusters, a very severe headache, usually in the middle of the night. And there's frequent suicides, you know, among those. Men are more likely to suicide than women because women are more forbearing, and so that's a particular association with what's called cluster headache, which is uniquely kind of more of a male migrainous variant, you know. But in Chiari, I think there really is no associated with that. I find Chiari patients are usually quite high functioning patients, and they're, you know, there may be a selection bias, and that a lot of these patients get to specialized centers, but I think, you know, they're very self-motivated and to try to get at the base of this. It's just that the medical community kind of lags behind in their understanding of this particular kind of headache problem and what can be done to treat it, and when is surgery indicated.